Well, good evening, everyone. I'm Dr. Leanne Brady, and thank you for joining us this evening. And in this webinar, we're going to talk about tips and tricks for anterior veneers and making veneers easier. So I want to just start, as always, I want to thank Viva Learning for hosting this education and to GC America for being our sponsor for this evening's program. And so when I think about anterior veneers, my experience is I think in most dental offices, we tend to probably do fewer veneers than we might be able to do based on the clinical presentation of our patients. And when I think about why that is, there's a lot of reasons that go into that why. The reality for many of us is that we have a sense of safety with doing full coverage crowns versus doing veneers. But the reality is most of the time when we think about doing veneers, there's a lot more work that goes into veneers. They can often be more, harder to diagnose, harder to prep, definitely harder to provisionalize, and then of course you have the seeding process. But they are a more conservative restoration, and often with a well-done ceramic veneer, we can accomplish the patient's aesthetic and functional goals. We can preserve a lot of tooth structure, and especially in a younger person, we're leaving a lot of tooth structure for the rest of their life for any potential future restorations. So what I'll do this evening is talk about some tips and tricks for me that really made veneers predictable enough and easy enough that in my practice, I actually would tell you I probably do more anterior veneers than I do anterior full coverage restorations. And that wasn't always true, because I was in the group of people who thought about doing veneers and kind of wanted to groan just because of the technique sensitivity piece. So where does this process start for me? It starts with treatment planning. And veneers are not always the appropriate treatment. Sometimes we do need to own the lingual surface of the anterior teeth due to excessive wear, excessive erosion. We're changing the functional constraints of the tooth, so I need to have the lingual of the maxillary anterior teeth as part of the restorative process. And sometimes I actually need to do full coverage because of what I want to do as far as instant ortho or alignment and changes, and my practice design is going to drive doing full coverage. But in the absence of those reasons, I want to preserve as much tooth structure as possible, and so I'm going to look at lots of preoperative photographs, potentially models of the patient. I'm going to sit with their pre-op situation. What are their post-op goals? What are the conditions of the teeth? Where do I have caries or prior restorations? And then we're going to go through a treatment planning process. And that process for me is critical because it is how I make the decision on margin placement, which ultimately drives whether it's partial coverage or full coverage. It also tells me yes or no, am I breaking contact, how much change I'm making additively or reductively to accomplish my aesthetic or functional goals. It drives my material selection. So a lot of planning goes in on the front end. And then one of the things that is unique about veneer preparations is there really is no stock or standard veneer preparation. And so oftentimes we talk about that as, minimal preps or conservative preps. The opposite of that, of course, would be something called an aggressive prep, I guess, which I don't think is, appropriate terminology. So really the question when we're doing veneers is, what's the appropriate tooth preparation to meet our clinical goals? And so often we have a situation like this. All of the margins were placed equigingivally or at the level of the tissue. Right now there is retraction cord in, so there's been some retraction. I did not break contacts in any of the teeth in this case, and we are going to cover the incisal edge with 1.5 to 2 millimeters of ceramic. So, yes or no, is this the appropriate preparation design? In this case, I've got really great preoperative tooth color. We're not changing tooth color dramatically. We were doing the restorations to do some alignment changes, to correct some damaged enamel, and to lengthen the teeth. So for that purposes, doing a really minimal thickness of ceramic, so 3/10, 5/10 is appropriate. And in this case, if you look at the space between the two upper front teeth, if I really wanted to close that space, make sure I guaranteed there was no black triangle there, I would want to break those contacts. In this case, the patient actually wanted me to preserve that little black triangle because she actually liked that part of her smile. So if we are going to try to change the contour of a tooth, we're trying to change, close a black triangle, change the length of the contact, then we are going to want to break contact. When we break contact, as you can see in this case, we don't have to break it both on the mesial and distal. You also might break contact because you're chasing caries or because you have a pre-existing class 3 composite restoration that you want to incorporate. So this is a patient that was actually doing a trail run in the mountains here in Arizona, tripped and fell, hit his front teeth on some rocks, did some damage to the incisal edges. Again, really thin amounts of ceramic that are going to go on these teeth. So 0.3 in the gingival, 0.5 in the middle, up to about 0.8 as we approach the incisal part of the prep, because I've got really good pre-op tooth color. I'm not changing the color in the final restorations. We're going to match his natural dentition, and I'm doing this so that I can cover the incisal edges. And in this case, he actually did have a small diastema, and while we were doing the restorations, wants to close those. So I broke contact on the mesial so that we can actually fill that space in, but I didn't break it on the distal. And in this particular clinical situation, I did something called a slice preparation. So one of the tricks with veneers is we want to make sure that there are 3 planes of space on the facial: gingival, middle, and incisal. Veneers seat by seating at the incisal edge and then rolling to place at the facial free gingival margin. Those 3 planes of space make sure that we maintain enamel thickness in all of the planes of space for maximum adhesion. It also makes sure that we don't have what we call show through from a place in the middle third that we overly prepped and exposed the dentin. And when we do a slice preparation like this, really important that we just push the burr straight through to the lingual. And so you can see that I did not wrap my prep around to the lingual. If you wrap around, you change the draw, and then you have to change the facial of the preparation, and you do risk now increasing dentin adhesion and show through. So a slice preparation is a great way to open the contact, but can be a little trickier prep design. And then you can also do the prep design where you actually leave a wall of enamel or tooth structure on the lingual. Some people refer to this as a shoulder preparation as you've broken contact. This is usually an easier prep because you don't have to worry about changing draw, but being able to do this really depends upon what percentage of the contact lives in the thickness of the tooth. And so if you have very triangular shaped teeth, as you break contact, you're not going to actually have a nice wall on the lingual, and you'll probably have to move to a slice preparation. And so how much ceramic you're going to put on the facial of these teeth really has to do with what are you trying to accomplish. The more you're trying to change shade, the thicker the ceramics tend to want to get because you obstruct or opaque out more of the color of the original prep of the tooth. And often the reason that we're doing veneers is to additively change the aesthetics, tooth alignment, tooth position, or contour of what the original teeth look like. So when we think about moving that process through, we have to start with treatment planning. We have to have an idea of what aesthetic changes we want to make, what functional changes we want to make. What's our pre-op color of the teeth? What's the post-op color after the ceramics? Therefore, how much thickness of ceramic do I need to help me get to my final color? So all of those things are treatment planning decisions, and that's actually going to drive my prep design, and it's also going to drive my materials choices, and all of that happens before I actually get to the phase where I'm going to start preparing teeth. And then when I do prepare teeth, for me, there's a lot of very specific pieces of this that make doing veneers easier. And one of those we're going to go through in depth, and that's the process of doing a mock-up. The other pieces of this puzzle are working with a laboratory who's not only going to do my wax-up, but that I actually ask for what we call a wax-up kit back. And it comes with the wax-up, but it also comes with all of my prep guides. So an incisal edge reduction guide, a labial reduction guide. It's also going to come with the way to make my mock-up, so a silicone matrix to do a mock-up, a silicone matrix to do my provisionals, and all of the pieces and puzzles that I need to make sure that I make enough space between where I put the teeth and the wax up or the proposal for the ceramics and to meet the treatment planning goals that we had for the case. And so starting with a really well thought out treatment plan, lots of photographs, and working with the laboratory and discussing the outcomes we want, so that that drives the wax up, and then the wax up is going to drive the prep by using all of my prep guides, for me is one of the tricks. It's actually much more complicated to prep teeth for veneers than full coverage, and I need lots of little ways that I maintain the precision in that technique. So as I said, it starts with a treatment plan. And so for me, when I think about a treatment plan, I'm actually going to take the patient's pre-op photographs, and I'm going to say, where do I want incisal edge position? Where do I want free gingival margin? Are we trying to change the width of the teeth or spread the arch length over different teeth, which would necessitate me breaking contact? Again, pre-op color, post-op color. I'm going to send all of these photographs, and I do send a photo like this often where I've got my treatment plans sort of outlined, to the laboratory. And then what the laboratory is going to do is they're going to generate a wax up for me. And so it's really important. One of the tips or the tricks in doing partial coverage restorations is that we're going to work from a wax up when we do an anterior aesthetic case or a veneer case, because so much of the time it's additive, which allows us to not have to reduce as much tooth structure. And some of the time it's reductive. You have a tooth that's way out on the labial of the arch, and you actually have to prep the tooth back into the arch form and then make space for ceramics. So being absolutely precise about your prep design requires doing a wax up. And with veneers, I want the patient to get to see the final tooth position, tooth shape, tooth contour in the provisionals, so that then they approve the aesthetics in the plastic phase, and then the laboratory can copy that. So there's lots of reasons that a wax up is super important. But when you get a wax up from the laboratory, they need to know which teeth you're going to prepare for partial coverage and which teeth you're going to prepare for full coverage. And they need to have an idea on your partial coverage restorations, where are you going to place the margins? Because they need to wax to those contours. It can be extremely frustrating if you prep a tooth for full coverage, but it was waxed partial coverage. Or you prep it partial coverage and they wax it full coverage, because that frustration is going to show up in the part of this that that we're going to see when we think about doing the provisionals. And so it's really going to become a challenge when we think about doing this from a standpoint of our provisionals. And what we don't want to do is have lots and lots of excess bisacryl that we have to trim off. And we also don't want places where the bisacryl is too thin, because the wax up actually wasn't prepared where we're going to actually be prepping the teeth. So the wax up and the wax up kit, and really working with your laboratory to get an exquisite wax up kit, is going to be one of the critical pieces of being successful at veneers and not feeling frustrated. And then, as I said, the precision that's required from a standpoint of thinking about the prep and making sure that you make adequate space for restorative material. So you'll notice that I'm trying not to say that you've reduced properly. And the reason I'm not using the term reduction is because most of these cases incorporate some sort of an additive component to correcting aesthetics and function. So if you're going to actually increase tooth length by 2 millimeters, you actually don't have to prep the incisal edges, because 2 millimeters is the amount of space we want to leave for ceramics on the incisal edge. If you have a patient who's had a lot of excessive acid erosion on the labial of their maxillary anterior teeth, and so in the wax up, you're actually adding back the lost tooth structure from the erosion to the tune of 5/10, 8/10 a millimeter of restorative material, that you won't have to truthfully prep those. And so we want to make sure there's enough room for restorative material. And so the way we do that is we actually prep back from something called a mock-up. So when I do anterior aesthetic cases, one of the very first things I do is I do a mock-up. So the laboratory has sent me a full arch silicone matrix that replicates the wax-up. Now, if the case is purely additive, you can go right to the mock-up phase. If the case is what we call additive reductive, the laboratory will have sent you what they call a reduction guide. And classically, that's a clear BioAcryl suck down that goes over a stone model. And often on the stone model, they've actually highlighted in black Sharpie marker where they actually reduced the contour of the tooth prior to initiating the wax up. And what you'll do first is you'll actually relieve those areas that have been marked in black Sharpie marker until you can get the clear BioAcryl matrix over the teeth passively without it binding in those areas. Then you're going to do your mock-up. And so when you do your mock-up, and I'm going to show you a video of doing this, there's a lot of reasons to do the mock-up. I try most of the time to do my mock-up prior to the patient being anesthetized. I want them to maintain their lip mobility. So I'm doing the mock-up partly for the patient. It's the first chance for them to really see what their teeth are going to look like at the end of this appointment and get excited about the outcome. Some people actually will do a mock-up at just a separate appointment as a way to increase case acceptance. But if you've not done that, this is a great way to get the patient excited on the front end before you get them numb and you do all of the things we do in a veneer prep appointment. It's also a way for me to verify that we've met the goals that I set aesthetically and functionally in the wax-up. So as you'll see in this picture, often I test the function. So this patient has a bisacryl mock-up on their teeth, and I'm just checking my edge-to-edge position. I often, if there's a lot of changes I want to make, I'll actually make them right in the bisacryl. We'll take an alginate after I modify the mock-up, and then we will actually make a new matrix to make our provisional, so we don't have to make those changes twice. And the mock-up is really critical for making sure that I've created adequate space for restorative material without removing more tooth structure than I need to. So what we're going to do is I'm going to show you a video of just doing a mock-up. And so this is actually the case you were just looking at the static photograph of. And so when I do a mock-up, the very first thing I'm going to do is I am going to spot etch. So the patient's not numb. We've not done any tooth preparation. So I'm just using 35% phosphoric acid, and I'm just doing what we call spot etching. Spots typically always 3 millimeters or so. You do want to let it set for 25 or 30 seconds since this is enamel. I did edit that out of the video. And you're going to just rinse and dry. I'm not being overly precise in my isolation or how I'm rinsing and drying because this is not for a final impression or anything like that. And then I'm going to take my full arch matrix that I got from the laboratory, load it with bisacryl, and so you can load it with GC's Temp Smart material. And now you're going to leave it in the mouth until it comes to an absolute full set. So whatever the set of the material is, and so they range from bisacryls a lot of times 3 minutes to 5 minutes. Now what you're going to do is you're just going to go in and you're just going to remove all of the excess. The excess on the lingual should just peel off like this. It should be very, very thin. And one of the ways you know that you seated the matrix properly is that the material that actually is over the gingival tissues should pop off like this. So in a really well-fitting two-stage silicone matrix that you've seated properly, the material should actually almost be perforated right at the gingival margin, and it should pop off without breaking off of the actual surfaces of the teeth. So then what you're going to do is you're actually going to now evaluate your mock-up. So I'm actually going to go back one slide so we can see the final product. So this is that mock-up you looked at. So before we do anything, we need to evaluate that that the mock-up was done properly. And so, if you overseat a silicone matrix or the matrix was not thick enough or rigid enough, it tends to flare at the free gingival margin, and you'll actually get buccal thickness. And it will also, the teeth will be shorter than they were in the wax-up. If you underseat the matrix, the teeth would be longer than they are in the wax-up, and we need this to be a replica of the wax-up. So there's 3 things that I do to make sure that my mock-up is accurate. The first thing I do is I evaluate the thickness of the bisacryl at the free gingival margin. And as I said, it should be feather thin. I should not have a lot of thickness of material right at the free gingival margin. If I do, it means that I overseated the matrix and flared the gingival part of the matrix, and the material was allowed to sit thicker at the free gingival margins. The next thing that I do is I actually take out digital calipers, and I'm going to actually measure from the free gingival margin to the incisal edge or the cusp tip in 4 spots on the mock-up, and compare that to the same 4 measurements on the wax-up. I'm going to measure the most distal tooth on the right and the right central incisor. I'm going to measure the left central incisor and the most distal tooth on the left. And from free gingival margin to incisal edge or cusp tip, if you're using a canine or a premolar, those measurements, those 4 measurements, most distal tooth and the 2 central incisors, should match the wax up to the mock-up exactly. If your mock-up is longer, you underseated the matrix, and if your mock-up is shorter, you overseated the matrix. If there is any discrepancy between the mock-up and the wax-up, you need to just pop the mock-up off the teeth, clean the air-inhibited layer out of your silicone matrix with something like rubbing alcohol, load it up again with your Temp Smart, and do it again. There is no point in having the patient evaluate the aesthetics of a mock-up that's not an accurate replica of the wax-up. There's no point in wasting time adjusting the function, and it certainly doesn't make sense to now use your mock-up as the way to prep the teeth and trust that your depth cuts are going to be accurate in creating space for restorative material if it's not accurate. So a mock-up to me is one of the most critical steps in creating predictability in veneers and verifying that the mock-up is accurate by using a digital caliper and doing those measurements. And so then what I'm going to do is I'm going to do all my depth cuts into my mock-up. So I'm going to do my incisal edge depth cuts into my mock-up, my facial depth cuts into my mock-up. And one of the things that I will tell you that creates the precision we need when we're doing veneers, because it's very, very difficult and tricky with your eye to judge that you actually have 0.3 of a millimeter of restorative space, especially as soon as the mock-up is off the teeth, because you have no reference to the final labial tooth position. So using the right armamentarium, so using really accurate depth cutters, using burrs that are actually designed to cut for veneers. We use a different armamentarium when we do veneer preparations than we do full coverage preparations. As I said, we have 3 planes of space on the facial, not 2 planes of space. And so you can see in this particular clinical slide, the other piece of this is having reduction guides. So this happens to be a facial reduction guide that's actually made of an acrylic material that I get from my laboratory, Gold Dust, as part of my wax-up kit. And you can see here in this case, I have 1 full coverage crown, and then the rest of the teeth are veneers. And you can very easily see the amount of space that was made for restorative material is dramatically different between those different preparations. And you can see the curved 3-plane nature of the facial of the veneer preparations versus a crown, which is 2 planes of space, 1 plane from margin up to the incisal third, and then just a beveled incisal third. So starting from a wax-up, using an accurate mock-up, doing depth cuts with the right armamentarium into that mock-up, and then measuring again using reduction guides to verify that your preparation design has been accurate, for me are going to be really critical tricks to creating predictability. And so once you get the teeth prepared, then you're going to move into capturing some laboratory records and then have to provisionalize. And provisionalizing in the world of veneers is probably one of the more frustrating pieces of doing veneer restorations. And so there are 3 different ways to fabricate provisionals. One is a direct technique, which is what we do classically for a single unit crown in the posterior. It means you actually allow the bisacryl to be shaped against the preparation in the oral environment. Another is what we call an indirect technique. So you take an impression of the prepared teeth, you pour a model of the prepared teeth, and then you actually fabricate the bisacryl provisionals on a model of the prepared teeth, not actually in the mouth. And the third technique is called a shrink wrap technique. And so I will tell you that for years I tried doing veneer provisionals, both direct and indirect. And when I finally learned a shrink wrap technique, I thought, where has this been all my life? Like that it is the solution to loving doing veneer provisionals. I actually would rather do a set of veneer provisionals today than do a set of full coverage provisionals because they're quicker and easier if you use a shrink wrap technique. Like everything, there is a technique to it, and if you don't know sort of the tricks to the technique for shrink wrap, you will hate this technique. So one of the truths about veneer provisionals is that they come in 2 kinds. The kind that fall off constantly, and you just make the patient an 8 o'clock standing appointment every day to fix them or put them back on, and the kind that you cut off. And shrink wrap provisionals are the kind that you have to cut off when you seat them. So, you know, trick number 1 with a really beautiful veneer provisional is to work with a very nice bisacryl material that has really good aesthetics and really good physical properties like GC's Temp Smart. And when you do a shrink wrap technique, what you're going to need as one of the critical pieces of the technique is a very well-fitting, very rigid 2-stage silicone matrix. And adding to that, an additional piece of the technique that's very valuable and made my life much easier is to actually use something called a bead line 2-stage matrix. And you're going to actually have to carve a stone model that is a replica of the wax-up using the triangular end of a cleoid discoid instrument. And you're actually going to create a track in the model that creates a silicone gasket on the inside of your 2-stage matrix. And so I make my 2-stage matrices, or I have the laboratory make me a 2-stage matrix with a bead line system. When I get my wax up kit, what you're going to do is you're going to take a putty silicone impression material or silicone laboratory putty material, make a matrix, let it set, trim it back, and then you're going to load that putty matrix with light body impression material from the same impression material. Like, so you could use the putty and the light body from GC's Exaflex system, and then that's a 2-stage matrix. And so what we're going to do is we're going to watch a video of doing some shrink wrap provisionals, and we'll get to walk through that. So as I said, for me, the added accuracy of the bead line technique is critical. So I or my laboratory take a stone model of the wax-up. We take the cleoid side of a cleoid discoid, and we actually carve a trench so that then when we make our 2-stage silicone matrix, the light body material actually goes into that triangular little slot and actually creates a really nice silicone gasket so that it fits very tight right at the free gingival margin and gets rid of all the excess material. So in this case, we've got a patient where we did 3 teeth for veneers, a lateral and 2 centrals. Before you do your shrink wrap technique, you want to make sure you've gotten all of the records that you need for the laboratory. So you have your prep photographs, you have your dye shade photographs, you've got your final impressions, you've got your FACEBO or DFA, you know, that you do not need to get back to these prepared teeth for anything after you do the shrink wrap provisional technique. And so the first thing I'm doing is I'm just cleaning the preps. This is just 2% chlorhexidine that has been pulled up into a syringe to irrigate. This is not Paradex or PerioGuard or any of the mouthwashes because those contain glycerin and flavoring elements that will interfere. It's just plain 2% chlorhexidine prep scrub. And then I'm just going to rinse it and dry it. One of the pieces of this puzzle that I do is I do spot etch. People ask me all the time if this step is necessary, and there's a part of me that has to say no, it's not, but I've done it this way for years, and so I do continue to etch with 35% phosphoric acid for about 20 seconds, and then rinse and dry. I'm just going to dry with my air water syringe. I'm not even using my ADEC air dryer because these are provisionals, so it's not like I'm trying to permanently bond here. A critical piece of this step is to paint the teeth with something that contains glutaraldehyde and HEMA. This happens to be Gluma. It prevents the black scuzz from growing underneath your provisionals, so that's critical. I don't rinse it off. I actually just blot it dry, and so I just leave it behind on the prepped teeth. And then we're going to go ahead and we're going to actually fabricate our provisionals. So I'm going to actually just now take my two-stage matrix, and I'm just going to load it up, and I'm going to just put my bisacryl material into my matrix, just like you would if you were making any provisionals. And then we're going to go ahead and then we'll just seat that on the teeth. You know, one of the tricks, of course, to not getting air bubbles is not to pick the tip up or move it in and out. So I actually layer my bisacryl back and forth. But once your matrix is loaded, you're just going to seat it over the teeth. And now you're going to allow this material to come to an absolute complete set, whatever that happens to be for the bisacryl that you're using. And I classically hold this in place. You'll see here in the video that I have the patient holding it. The patient's actually a dentist, and I was fussing with the video camera, so I asked him to hold the matrix. I don't normally do that. I usually hold it the whole time. So we're not going to watch this, so I cut a couple of minutes out of this video because now this material is going to be completely set. So you're just going to pop your two-stage silicone matrix off. Now, the first thing I'm going to do is I'm just going to take a 2x2 that's basically drenched in rubbing alcohol, because that'll actually get rid of the air-inhibited layer or the sort of gooey layer of bisacryl. And because of the two-stage matrix and the bead line accuracy of fit, now I literally can just pop off all the excess. So this material literally just perforates right at the margins. You can even pull the material out of the interproximal. You are not going to pop these provisionals off of the teeth because they're, you know, that's how secure these provisionals are. And so I'm just using a, you know, a scaler there. On the lingual, the material will peel off just like it did with your mock-up. It's just a very, very thin layer that covers the unprepared part of the tooth. And so you can just peel that off right at your butt joint at your incisal reduction. So at this point, you know, I've only used hand instruments, and, you know, you pretty much are seeing the video, and I can check my margins, and I'm pretty much flush with my margins. So I am going to use a speed reduction attachment for my electrics and a mosquito diamond, a fine mosquito diamond. And all I'm doing is I'm going to open up each of the gingival embrasures. I'm going to do this from both the facial, and then I'll go back and do it from the lingual. The goal being so that the patient can pass a floss threader between every contact. Brownie points, or brown silicone points, I use because they cut composite resins or bisacryl very, very quickly and easy, and they won't cut enamel or tooth structure at all. So anytime I want a nice infinity margin between a resin-based material and the tooth, I use a brownie point going at slow speed. And again, I'm going to open the gingival embrasures from the lingual. Having the ability to pass a floss threader basically tells me that I'm not putting too much pressure on the papilla, which would then press the papillas down and result in it looking like I have black triangles when I try my veneers in. So then I'm going to just check my occlusion. You know, the wax-up was done on a set of models that were mounted on a semi-adjustable articulator and adjusted by setting condylar inclination, so there's really not a lot of adjustment that needs to be done. And then we're just going to polish in the mouth. So these happen to just be Brasseler's Feather Light polishers. They do make these now for resin-based materials, so you can use these. You can use any type of composite or resin-based material polishers. These run at slow speed, so you do like 14,000 RPMs, 10,000 RPMs, and then 7,000 RPMs. And you're just going to get a really, really nice high shine on these so that they feel as smooth as possible to the patient's tongue, and they look really nice and aesthetic. So in this particular situation, as I was polishing, I noticed a little air void. It happens to all of us. And so I just cleaned it out. I'm just going to use the matching shade of flowable material to the Bisacryl that I used, fill it in. And what I'm going to do here is just make sure that it's dense. And then I use the side of a Piggytail Explorer to just make sure it's flush and then light cure that. And then my final stage of polishing always is just with diamond polishing paste. So once you get these all done, you've got this great set of shrink wrap veneer provisionals. And these provisionals will stay in place for quite some time. My instructions with veneer provisionals, and this is part of the tricks, is I say to the patient, you have to eat everything on a knife and fork. And they say, okay, so can I have pizza? And I say, only if you eat it on a knife and fork. And then they say, can I have a sandwich? And I say, if you cut it up and eat it on a knife and fork. It normally takes about 3 foods before they go, oh, so I can't bite into anything with my front teeth. And I say, absolutely, until the night before your next appointment. And then if they have a bagel or pizza the night before and make the provisionals loose, that's just a bonus from my perspective. So then once we're done with provisionals and patient-approved provisionals, I take an impression, send it to the laboratory so they can copy that. Ultimately, we're going to get our restorations done. So let's talk about putting in veneers and some tricks to make that more predictable. The first one is we have to try all ceramic restorations in with some form of try-in paste. So you actually have to couple the ceramics to the color of the tooth underneath for the patient to truly evaluate the aesthetics of the restoration. If you try them in dry, the ceramics will look brighter, whiter, higher in value, lower in chroma than they will once you bomb them in, and the patient will think that they are changing colors or turning gray after you bomb them in. So buying the companion try-in pastes is really a critical component of allowing the patient to approve the aesthetics. And then we're going to use adhesive placement when we place veneers. Veneer preparations have little to no mechanical retention, so everything we're going to get is going to be from adhesive retention. And so after you try the restorations in, the patient has approved them, then you're going to need to either clean if your laboratory has already etched or conditioned, or you can do this process. And so, you know, most of the time if your laboratory is doing this, it makes it easier for us. There are lots of different ceramics on the market today. They don't all require the same type of etching with the same chemistry or for the same amount of time. So if you are going to prepare the ceramics in your office, you need to confirm the laboratory didn't do it, and you need to confirm exactly what the manufacturer's protocol is for that particular type of ceramic. For me, I think it's easier for the laboratory to go ahead and etch the ceramic. I can try it in. Once I've tried it in, I'm going to wipe the try-in paste out as best as possible. And then what I'm going to do is I'm going to clean the inside of the ceramics so I get back to that nice etched surface so that then I can go ahead and know I'm going to get maximum adhesion to the ceramics. Once the ceramics are cleaned and dry, then we actually have to place like a primer or silane. Today, I think for most of us, we're using something like G-Multi Primer. It has different chemistry in it, so no matter what material you're bonding in, it will condition that. So you don't need to know the exact type of ceramic. You can actually use it on non-ceramic materials as well. And you're going to put this in, let it sit for, you know, depending on the manufacturer's recommendation, 20 to 60 seconds wet, and then you're going to really thoroughly air dry that. And then for me, I set my restorations aside, and then I'm going to move into my cementation process. So one of the things to find out from the laboratory if you're seeding multiple veneers is there a cementation order? So the preps side by side don't always draw in the same line of draw. And so the laboratory can get you a little cheat sheet that, you know, you have to seat them from right to left, or you have to seat number 7 before number 6, so that you know they'll all go to place. So figuring out what the order is the restorations have to go in, and if it's not just you can choose, is going to be important. I try every restoration in dry individually to check my margins. Once I know all the marginal accuracy is there, I now try all the restorations in dry together. Number one, I can check and adjust contacts and adjust and polish as needed. And if there is an order they have to go in that's specific, I'll learn that if I don't already know it from the laboratory. Then I'm going to try all of the restorations in together with try-in paste so that the patient and I can approve the aesthetics of the ceramics, and we know we like the value, chroma, U, all of the things about that. If everything is good at this point, we're going to clean the ceramics, then we're going to apply our G multi-primer, dry that, and now I've put them in sort of an organizer that sorts the restorations. So now I'm going to actually go to preparing the teeth. And so when we think about actually what your cementation sequence is, your cementation sequence is going to be specific to you. Some people like to seat veneers 2 at a time. Some people like to seat them all at once. If you do seat 2 at a time in sections, we always seat the centrals first. Then we're going to start seating canines, premolars, posterior teeth, and we always seat the laterals last. The reason we do that is before you seat the laterals, you'll try them back in. You probably will have to make some slight adjustments to the contacts and repolish and re-clean the ceramics. And laterals are the teeth that have the most ability to be asymmetric. So we always do the lateral incisors separately. Definitely there are some challenges to doing them in twos. As you do them, you have to clean the cement with each one, and then you have to deal potentially with tissue that starts to hemorrhage and can interfere with bonding for on the other veneers. The other way to seat is all at once. Seating all at once really is about learning the technique. I will tell you that probably the most important trick to seating veneers is to have 2 light curing units in the operatory with you, one that's your regular light curing unit that has a large diameter light guide or tip on it, and one that has what we call a 2mm tack tip. So the hardest thing about seating veneers is you've got this veneer, it's got veneer cements or resin in it that's you know, very slick, and you go to seat it, you've got to check the margins, and then you want to seat another veneer, and the instant you let go, the veneer can float or move around. And so for me, I take the veneer, I load it with the veneer cement, I seat it with and hold it in place with my left hand. I check the margins with my right hand. If it's good, I then hand my assistant the Explorer. She hands me a light curing unit with a tack tip. I put that 2mm probe right in the middle third of the facial, and I hit the light for 1 second, or as long as it takes me to press it on and then off. Now I can let my left hand or my non-dominant hand go, and that veneer is not going to move. But none of the excess resin that's out beyond the margins is cured. It's still liquidy. So I can seat the next restoration. So having a second light curing unit, so you actually can have 2 light curing units in the operatory, one with your normal probe on it or light guide and one with a 2mm tack tip, probably one of the best technique pieces I've ever learned of seating veneers. And then, of course, one of the critical pieces of seating with any type of a resin-based material is that we do want to cover all of the margins with an oxygen barrier. So you can buy just USP grade glycerin, or you can use the oxygen barrier or liquid strip that comes with the kit that you get when you are going ahead and using your adhesive cementation. So I know one of the challenges that I hear from folks all the time is that you know, they don't do a lot of veneers in their practice all the time, and you know, to buy a veneer kit just to seat veneers is expensive. They're, you know, they're costly, and they don't use it, and then it expires, and they end up throwing everything away. And so one of the advances in dental materials in the last couple of years is that we actually have figured out how to create dual cured resins that are absolutely color stable. And so a change in the chemistry in the photo initiator eliminates any risk of resins doing what we call color shifting over time. And so classically we said dual cure resin materials are just for posteriors because there is even today a small risk of color shifting. And when you're working with especially thin ceramic restorations in the anterior, that you want to use a light cured resin cement. So today, because we do have materials like GC's GSEM Link Force, which is a full adhesive system, so you get your bonding agent, you get your G-multi-primer, and you get your dual cured resin along with all of the components in the kit, and it's dual cure, but it's color stable. For me, that really allows us to have a lot greater inventory control. So you can use the GSEM Link Force for doing posteriors, so posterior full coverage, inlays, onlays. You can also use it for anterior full coverage, where you're not sure you can get light through because it does have the dual cure chemistry, and you could use it because it's color stable for your veneers. So one of the things to know when you're doing multiple units and you're using a dual cured resin is that it is going to start to set the instant that it comes through that mixing tip on the end of the tube. And so I don't ever preload my restorations. So we clean the ceramics, we silanate or prime the ceramics, we dry it, and then I load with the resin as it's going to the tooth. So I never preload. But if you are in the habit of preloading, you should not preload if you're using a dual cured material of any kind. And if you are using a dual cured resin, really understanding what the chemical cure time of the material is, and therefore deciding, do I need to do these restorations 2 at a time or 4 at a time, or can I do all of them if I'm doing 6 or 8 or maybe even 10 if you really work quickly. But you don't want the chemical polymerization to then become a challenge and you're really struggling to clean off all of the excess cement. So when using a dual cured resin like this that's colored stable, you've got the great gift that this one kit gives you the versatility to bond in anterior, posterior, full coverage, partial coverage, and because it's dual cured, you may need to alter your technique a bit and not preload the restorations and determine how many can you seed at once without playing beat the clock on the chemical polymerization. And it also comes in a variety of different shades, so it gives you that flexibility if you want to play with the shading to do some very minor adjustments or color correction to your anterior veneer restorations that, that you can influence the value just a little bit. So you've got those choices. So with that, I hope that those were useful tips and tricks, and I'm going to go ahead and do some questions before we finish up here, like in the last 10 minutes. And so we do have a question. So the question is, what do you use to clean the restorations before final cementation? Today, to clean the ceramics after you try it in, you really have two choices. One is a product called IvoClean, and the other is to just use your blue tooth etching gel. So you can clean try-and pastes, saliva, red blood cells, handpiece oil with traditional 35% phosphoric acid. So you can do that as well. Okay. So that's a possibility. So asking about putting the finish line, supragingival or subgingival. It's really not is one better or is one worse. It really is where do you want the finish line based on your clinical outcomes. I classically with veneers do equigingival, so right at the top of the level of the tissue. The only time that I go subgingival, it's rare in a veneer, but if I'm making a more dramatic color change, I will go subgingival. So then that if they get a little recession as they age around the restorations, you're not going to see it. So that's a question about that one. So then the next question, mock-up may not fit or may be too thin if you didn't reduce some of the teeth first. Possibly. So that's why I said if you have what we call an additive reductive treatment plan, your laboratory should send you a reduction guide, that clear biochrome suck down first, and you need to do the reductive process first, then do your mock-up. And then once you do your mock-up, it won't be too thin. Next question, how do you remove your temporary veneers? The way I do it is I obviously work under loops that are high power magnification, and I'm going to use my speed reduction attachment for my Brasseler electric handpieces. I put a little 330 burr in. I run it on the slow speed setting at about 15,000 RPMs and dry. I basically just put just a tiny little slit up the Vistacryl. I don't go through to the prep. If I broke contact, I go through the interproximals. If I'm covering incisals, I go through the incisal. I just put as many little vertical lines in the Vistacryl as I can, and then I take a crown remover, put it in every one of those little places, and just lightly twist. And then usually you split the Vistacryl, and you can just grab the margins with a universal scaler and pop everything off. How to use Teflon tape. If I'm doing my veneer seat or bonding and I'm doing them 2 or 4 at a time and I'm going to leave preps, I don't want to get any resin on those preps, so I'll actually cover the preps where I'm not seating with Teflon tape to make sure that I don't get any resin on those preps. Next question, before cementation, you use a glycerin. Actually, you don't want to use glycerin before the cementation. You use glycerin after cementation. So once the veneers are in place, you've tacked them. What I do next is I do a wave cure, and then I clean all the resin in a gel phase. Before you do your final cure, you want to cover all of the margins with glycerin so that you don't have an air inhibited layer that will pick up stain pretty quickly. How do you clean the tooth structure where you spot etched before the temp? So I actually am not cleaning, you mean cleaned where I spot etched after I take off the provisionals. A brownie point, sorry, I was thinking through the question. I just check to see if I left any resin behind. The way I do that is by just scraping on the prep with an Explorer. Resin will turn gray. Tooth structure will not turn gray. If I leave some little gray scratches behind, I put a brownie point in my speed reduction handpiece, run it on slow speed, and get rid of any residual resin. What is the best burr for prepping the tooth? That's a tough question to answer because I use a series of different burrs. I have an incisal edge depth cutter. I have 3 different facial depth cutters that do 0.3, 0.5, 0.7. So my suggestion would be if you don't have a veneer kit, that you can go to one of the burr companies, so Brasselers, who I work with, but certainly SS White or Axis, and you can buy a setup that's already done for veneers that may have the burrs that you like to use. Should we cure the bonding material prior to seating the veneer? So the answer to that question, and I kind of purposely didn't address it because it's manufacturer dependent. And so you need to read the manufacturer instructions for the resin system that you're using. If they require curing the adhesive first, then that's absolutely critical in getting to the right bond strengths. The reason for years we didn't cure first is we didn't want the film thickness of the bonding agent or the dentin adhesive to create an open margin. Modern dentin adhesives are less than 10 microns in film thickness when applied properly and then thinned properly, so that's not a problem. But the different manufacturers' kits have different recommendations. How do you deal with the cement in the interproximal area bonding 2 veneers together? A cool little tool from Axis that's called a seri saw. It is probably a must-have on every tray table when you're bonding in anything, veneers, crowns, inlays, onlays. It is the bomb at separating the interproximal. So Axis seri saw. So next question, you cut through the mock-up to prep your veneers. Yes, I leave the mock-up in place. I do all my depth cuts into the Vistacryl mock-up. That's how I know that I'm making enough room for ceramics, but I'm not removing more natural tooth structure than I need to. At some point, the remnants of the Vistacryl will just sort of fly off the tooth, but you've already got your reduction done, so that's great to do. Next question, what material do you use for your veneers? And hi, Lola, or Judy. So one of the answers to that, obviously, today would be something like lithium disilicate, so GC's Lyc Press, or some sort of a lucite reinforced ceramic. And so I actually use a lot of lucite reinforced ceramic. I love the aesthetics. I think it's really a natural looking material, and I use that especially if I'm not doing all of the teeth in the aesthetic zone or the smile zone. I will use a lithium disilicate if I need additional strength, if that's an important feature, and I'm doing all of the teeth. So those are probably the two most common choices today. How do you determine lingual margin placement ideally? The lingual margin, I never prep down the lingual wall. If you prep down the lingual wall, you have to create facial draw. That totally changes the dynamic of the prep. I always do a butt joint on the incisal, and I literally put it wherever I need to into my mock-up to get 2 millimeters minimum thickness of incisal edge ceramic. Next question is, do you do gingivectomies or gingivotomies in conjunction with veneers? And often we do, so if part of the treatment plan is to move the free gingival margin, absolutely. If it's just a gingivectomy, I'll actually do that in my office. I actually have a CO2 laser, and I'll remove soft tissue. If it's actually true crown lengthening where we need osseous reduction and then apical repositioning of the tissue, I actually will send that to my periodontist. I often prep the teeth. I place my margin where I want it, even if it's right at the level of the bone. I provisionalize the teeth, and then I send to the periodontist, and now my veneer margins become a surgical guide, and the patient can go do the crown lengthening without exposing roots and having the sensitivity and having the negative aesthetics. But you could certainly crown lengthen first, allow for healing, and then come back and do your veneers. How do I manage gingival bleeding at the seat appointment? Ideally when you're seating, if you could have a well-inverted rubber dam on every tooth. Sometimes that doesn't work. We use a split dam technique. I often place cord when I'm doing my seating, especially to like a size 0, just a primary cord. And then for me, my favorite way to control hemorrhage is retraction paste. Or some kind of a retraction paste. I happen to use 3M's retraction paste, but there's a lot of them on the market. And so the next question was, what was the name of the provisional material that I mentioned in the program? It's called Temp Smart, and it's a GC America product. All of our provisional materials are made of what we call bis acryl, and then there's lots of different brands of those. Next question is, if you don't break the contact in the prep, how do you clean the contact after cementation? So if you're not breaking contact, your interproximal margin needs to be a 0.5 millimeter facial to the contact. And then again, after the veneers are put in, I just open the contact with the Axis Seri saw. Best technique to load dual cure resin cement or any resin cement. I actually often hold the restorations myself. They're too slimy once they've got the resin in them for the assistant to pass them to me. So most of the time I'll actually load. So I put the ceramics in my left hand because I'm a right-handed dentist. I pick up the syringe, I load the restoration, and then I actually seat it with my left hand. Next question, what is the product you used after the chlorhexidine but before the provisionals? That's actually Gluma by Kulzer. It's a glutaraldehyde and HEMA. It's a prep wetting desensitizing agent. All right, and last question before we're done. Do I break contacts when prepping for veneers? Not always. I break contacts if I'm chasing interproximal decay. I break contacts if there's an old class 3 composite that I want to incorporate. I break contact to close a black triangle or to change the shape or the contour of the tooth. Whether or not I break contact is a treatment planning decision that's specific to that particular case. So, well, thank you, everyone. That was lots of great questions. So that was awesome. It's been my absolute pleasure. As we finish again, I want to thank Viva Learning for always hosting such phenomenal education, and thank GC America for sponsoring this and for bringing this to everyone. So I'm going to say good night and thank you, and hopefully you'll join me for another webinar again here on Viva Learning.